And thank you for joining us for tonight's International Dermatology Foundation Educational Series webinar. My name is Ashley with RBC Consultants, and the title of tonight's program is Demand More with BIMZELX Transformative Results for Managing Hidradenitis Suppurativa. As moderator this evening, we have Dr. Leon Kircik. He is Medical Director, International Dermatology Foundation, Clinical Professor of Dermatology, Icahn School of Medicine at Mount Sinai, New York, Adjunct Clinical Professor of Dermatology at Indiana University Medical Center in Indianapolis, Indiana, and Medical Director of Physician Skincare, DermResearch, and Skin Sciences in Louisville, Kentucky. As speaker this evening, we have Dr. Michelle Tarbox. She's Associate Professor, Chair, and Program Director, School of Medicine, Dermatology at Texas Tech University, Health Sciences Center School of Medicine. We would like to thank our supporter this evening, UCB, for making this educational event possible. Before we begin, a few logistic tips. If you're having issues hearing the webinar, please click on the audio pane and choose telephone so that you can get the call-in information. It will be displayed there. If you're having any technical issues, please submit your questions in the question pane. It's on the top right-hand side of your screen. At the end of the webinar, a survey will pop up in your browser and will also be emailed to you within 1 to 2 days. We would greatly appreciate it if you could fill out this short survey. Also, within 1 to 2 days of the webinar, a certificate of attendance will be emailed to you. If you have any questions at the end of our program, please submit your questions in the question pane on the top right-hand side of your screen. Now, without further ado, I would like to pass the floor virtually to Dr. Kircik.
Thank you, Ashley, and good evening, everyone. Welcome to another series of International Dermatology Foundation educational webinars. I'm very happy to present tonight a very dear friend of mine from Lubbock, Texas. But before we do that, International Dermatology Foundation's principal mission is to raise awareness and improve dermatology care all over the world, especially in underserved areas, of course, through education. And we have done several programs in the past, starting through the pandemic, and we serve not only US, but also Canada, the whole North America, as well as Latin America, Southeast Asia, as well as Europe. And please stay up to date with IDF Educational Series webinars, not only at LinkedIn, Facebook, but also Instagram. And you can also visit us at www.idfeducationalseries.com. So tonight, we have a very special program. A good friend of mine, Dr. Michelle Tarbox, who is the chair and the program director at Lubbock, Texas Tech University. She's going to tell us all about BIMZELX in Hidradenitis Suppurativa. Welcome and take it over, Michelle. Thank you.
Thank you so much. I really appreciate the opportunity to be here today to discuss one of the most underserved and undertreated conditions in our specialty of dermatology. So we're going to learn how we can demand more with BIMZELX, transformative results for managing hidradenitis suppurativa. And I love how transformative has the A and the F highlighted because it is actually IL-17A and F dual inhibition that are at the core of the efficacy of this powerful therapeutic. The connection is going to take a little while for some of the slides to load, so be patient with us. Now, on this previous slide, which I do need to go back to, I apologize. There is a very important disclosure that this is a program being presented on behalf of UCB. I am being compensated for this presentation. I donate all of my honoraria into a fund that I use to provide educational opportunities for my residents here in the underserved region of beautiful sunny Lubbock, Texas. And so I'm very grateful to each and every one of you for attending and learning with us tonight. Tonight we're going to learn about HS as a chronic inflammatory condition that's characterized by the formation of painful lesions in sensitive areas of the body. And those of you who treat patients with HS know that it's characterized by nodules, abscesses, and tunnels that can happen on the functional parts of our body, the skin that folds and allows us to move and function in the world. The physical manifestations of HS translate to patients reporting lesion drainage, foul odors and pain, and restricted range of motion. In fact, one of my patients, a very lovely gentleman, a dad who was in his 30s, who just wanted to be able to throw the ball for his little boy, came to us with severe axillary HS and a frozen shoulder. And his case actually inspired me to do a study on the connection between hidradenitis suppurativa and frozen shoulder joints, and there is actually a significant risk of mobility loss for our patients that have severe HS, because when you don't move a joint, it doesn't get the nourishment that it needs to stay functional. Our chondrocytes and our cartilage actually don't have circulation to them. The synovial fluid is how they get their nutrients, and when patients are in so much pain that they can't move a joint, they can lose that joint's function over time. There's a happy ending to this story, though. However, our patient was started on BIMZELX and was able to recover not only the function of his shoulder, but also the ability to move his skin without pain. And that's one of the reasons I'm here tonight, is because we can help our patients achieve their best quality of life and show up fully to be present in their lives for themselves, for their families, and for their communities. The physical manifestations of HS trigger psychosocial and functional impairment. The HS-specific symptoms of pain, drainage, discharge, itch, and odor can impede people's ability to fully engage with their work, with their family, and with their recreational activities. Psychosocial impact cannot be understated. This condition causes emotional distress, embarrassment, and social isolation. I have patients who have turned down promotions because of their HS. I have patients who have chosen not to attend a special occasion like a family wedding or a reunion because of their HS. And my own nephew suffers from HS. He's a really sweet young man. He's kind of a vintage kid, and he wanted to wear a powder blue tuxedo to his wedding. But unfortunately, his HS was acting up as it often does in periods of stress, and he had to choose a different outfit for his wedding day. Instead of getting to get married in the powder blue tuxedo he had always dreamed of, he had to choose a dark suit that could conceal the drainage that he was experiencing. We also spent more time changing his dressings on that day than he got to spend on the dance floor with his family. Now, again, a happy ending. He's on appropriate therapy. He's been married for about 10 years now. He's doing great, but that was a really difficult time for him. And we also know that HS impacts the daily activities of living. It can cause patients to have the inability to work because they can't physically sit in one space, because they have to attend to their dressings. It can impair their sexual functioning or cause them to completely just disconnect with that part of their life. And it can impair their sleep, which impairs all other areas of function. And as the severity of lesions and physical manifestations rise, especially in these sensitive areas of the body, so do the negative impacts of these conditions on the patient's quality of life. Patients, like I said, sometimes cut themselves off from the world because of the way that their HS impacts them. And some HS therapies may not offer satisfactory responses. Our patients deserve options that meet their needs. We had a really amazing experience when we were learning about this medication with UCB, and I really respect the way that they brought this drug to market. They had a summit where they brought actual patient advocates who have lived with HS, many of them for much of their lives, and they gave them the floor and allowed them to speak to us as healthcare providers, to educate us about what they need from their doctors and from their healthcare providers. And I got to meet a patient advocate that we actually had on the Dermosphere podcast, episode 146, if you want to listen. Her name is Miss Leah Ali. And we gave her the floor. We said, what would you like people who care for patients with HS to understand? And what she said is something I'll never forget. She said, we are not difficult patients. We have difficult lives. We're not looking for pain medication. We're looking for pain relief. We just want to be able to live without this condition pushing on us from all sides every day. Really, our patients can achieve that utilizing effective therapeutics. They can get pain reduction. They can have an improvement in their quality of life. The effectiveness piece can't be understated. Many patients have bounced from emergency room to suboptimal therapeutic, things that don't really modify the disease course. And our patients want to avoid disease progression because they know that every flare costs them more functional skin. We also want something that's going to be safe. Our patients want to know that these medications they're going to take are not going to be a bad decision down the road, and they'd like to avoid surgery. My institution is a regional referral center for hidradenitis suppurativa, and we collaborate with our burn surgeons, doing some of the larger surgeons with the burn surgeons to do the graft placements for the axilla, for the groin. We do the smaller deroofing procedures in our own clinic. There's a lot of surgical management of HS, and it can be very effective. But if a patient doesn't have to go through that, and even more importantly, through the healing process, which is very difficult to maintain graft health in a functional flexing part of the body, it would be wonderful to spare them that experience. There is an unmet need in the treatment of HS that BIMZELX is helping us to move the needle on, and I'm really grateful for that. Now, one of the really important things to understand about HS is the high score. The high score is defined by the kind of changes of the disease over time. So a higher high score would mean that fewer physical manifestations are present, including what's visible and beyond the skin surface. So high score assesses the percentage reduction in abscesses and inflammatory nodules throughout the body with no increases in abscesses or draining tunnel counts relative to baseline. So on the upper part of the slide, you see a patient at initial presentation. She has an inflammatory nodule count of 5 and draining tunnel count of 3. And you can appreciate that this patient now, after she's been on therapy for more than 6 months, has a high score of 100. We did not used to think this was going to be possible because HS is a structural disease and it is so difficult to treat. But this patient had a 100% reduction in her inflammatory nodules and draining tunnels with no new nodules or draining tunnels from baseline. On the bottom, you can see another patient with 4 inflammatory nodules, no draining tunnels. Now, I think most of us who treat HS could look at this patient and say, that is a disease that deserves to be treated. If you go by the old Hurley classification, which is helpful for many things, but should not be a barrier to patients getting access to efficacious treatment, this patient actually wouldn't qualify because she doesn't have draining tunnels, so she wouldn't be Hurley stage 2. Now, it's important to emphasize that the criteria have moved away from Hurley staging to moderate to severe disease, and that is a clinical definition, and it can be impacted by the area of function and the impact on the patient. I appreciate that they have put the decision-making process back into the hands of the healthcare providers who are really looking after these patients. So if you believe your patient has moderate to severe disease, that's a patient to think about treating with HS. And a reason that we want to think about this early is that early biologic intervention can delay progression to more severe stages of HS. You can see that HS is kind of like a not very fun roller coaster that many of our patients have been stuck on for a very long time, and it's defined by periods of exacerbation and relapse. Patients can go through multiples of these over the course of their disease state. We also know that as the disease activity progresses, functional impairment also worsens. And we also know that there is progression of the deterioration of skin quality and potential irreversible damage that's done. As good as our burn surgeons are at replacing the tissue in the axilla or the groin with skin grafts, that tissue will never really be functional tissue fully like native tissue would be. It's not going to move and flex the same way that tissue that isn't essentially scar would do. It's not going to do the thermoregulatory process that skin in those areas is supposed to do. And it's not as strong as normal healthy skin. And so patients have to be cognizant of that as they move through the world after those surgeries. So halting HS progression is key to successful treatment, which is why I'm really glad that BIMZELX exists as the first and only approved biologic that selectively targets the overly expressed IL-17A and even more importantly, IL-17F cytokines in moderate to severe HS. Now, very interestingly, we know that HS involves an overexpression of the IL-17 pathway. We know that IL-17A and F both play a key role in the follicular occlusion and dilatation that starts the process of HS, and then the inflammatory process with the production of the pro-inflammatory cytokines and the high levels of IL-17A and even higher levels of IL-17F that are produced. We also know that over time, disease progression goes forward to tract formation because our body is trying to do what it's programmed to do. It has identified this inflammatory process as something that needs to exit the body. And so it's trying to make exits for this process. And unfortunately, because the call is coming from inside the house with HS, it's a dysregulated immune response. The body can't clear this like it would if you had, for example, a splinter, or here in beautiful sunny Lubbock, Texas, we see a lot of buckshot that works its way out of people's skin. When you're dealing with HS, the structures and the inflammation belong to the skin. They're just inappropriately activated. And this persistent inflammation can lead to sinus tracts, tunnels, irreversible damage, and rope-like scarring that can compromise function and cause pain, as well as persistent drainage, itch, and odor. If we can avoid that progression, that can be a great benefit to our patients. We know IL-17F is a key driver in HS. It is overexpressed and more prevalent than IL-17A. It becomes the dominant cytokine that drives the inflammation, and the IL-17F expressing cells are found to be highly associated with HS tunnels. If you look at a microscopic picture of an HS tunnel, and as a dermatologist and dermatopathologist, I do that from time to time, it looks like how you might see an outside of the theater in New York City when the star is exiting the building and all of the people are crowded around the edges and nobody can get through, right? There's congestion. There's excitement. But unfortunately, it's not a fun kind of excitement. There's inflammation. Those Th17 IL-17F expressing cells are hanging out and causing a lot of inflammation and drainage and actually hyperproliferation of the epithelium lining the sinus tracts, which makes more debris and more drainage and more food for bacteria. It truly is a vicious cycle. And what's wonderful about BIMZELX is that it's able to get in front of both the IL-17A and IL-17F, as well as the IL-17A and F heterodimer that can help drive that process. So very efficacious and very targeted. Now we can see that there's elevated gene expression of IL-17A and IL-17F in lesional HS skin when you compare it to healthy tissue. And I want to draw your attention to the 155 times increase in expression of IL-17F in lesional skin. That entire piece of the inflammatory puzzle is not being treated by the other available agents on the market, and is, I think, one of the reasons that BIMZELX is so efficacious in treating this disease state, because you're precisely targeting the real rabble-rouser in this condition. We know that those dimers, IL-17AA, IL-17AF, and IL-17FF, are able to bind to the receptors and cause inflammation. We also know that being able to bind all of the isoforms of those inflammatory cytokines can provide more inhibition of inflammation than binding to IL-17A alone. And I think that the cellular mechanism of this is very exciting. So being able to blockade both of those inflammatory mediators can help us to give patients more significant results. Now, what's really wonderful about this medication as well is that there's more than 100,000 patients treated with BIMZELX worldwide. It's the #1 fastest growing IL-17, and actually IL-17 or IL-23. So it's the most quickly growing IL, interleukin inhibitor, in all comers for IL-17s and IL-23s. You can see that there's been 14 phase 3 and 3B clinical studies in psoriasis, psoriatic arthritis, non-radiographic axillary spondyloarthritis, ankylosing spondylitis, and HS, and 150,000 total patient years of experience across indications. This medication is approved for adults with moderate to severe hidradenitis suppurativa, which is a clinical definition, in addition to moderate severe plaque psoriasis in patients who are candidates for systemic therapy or phototherapy, active psoriatic arthritis, and there's also multiple countries, 23 regulatory authorities, and 52 countries that have approved the use of this medication, which gives me great confidence in both its efficacy and its safety. I said earlier that we didn't used to think a high score 100 would be possible, but this medication has allowed us to raise our expectations and also change our patients' expectations. When our patients come to us, they are looking for something that works. And they're suffering. They've been suffering for a long time. Often they've been waiting for their appointment with us for a long time. By the time they get in our room, by the time they get in our office space, they're desperate for something to work. And one of the wonderful things about this medication is you can see rapid results as early as week 2. That's very reassuring to the patient and helps you to establish trust with them so that they know that you understand how significant this condition is and how much it's impacting their day-to-day life. What's really phenomenal about this medication is 22% of patients already were able to achieve a high score 50 as early as week 2, and that increased to 60% of patients by week 16. The patients also had rapid improvements in worst skin pain as early as week 2, and these results were maintained over the 16 weeks that they were being assessed by the HSSDD, which is a patient-reported outcome instrument that was specifically developed to assess the patient-perceived severity of the 5 core HS signs and symptoms. There was so much intentionality toward the patient experience with the rollout of this medication, and so much attention given to the real impact this disease state has on patients' lives. And our patients can see and feel the difference. So you can see here a patient who has, just in this photo, inflammatory nodule count of 1 and 3 draining tunnels. This patient is in constant pain. He's having daily battles with stains and bandages, and like my nephew, was only able to choose to wear dark-colored clothes because he needed to conceal the drainage that he had to deal with every single day. Now, what's really wonderful to see is by week 16, the inflammatory nodule count and draining tunnel counts are down to 0. Phenomenal improvement. Now, when you start this medication, it is vital to educate your patients about the fact that HS is a structural disease. So you can see that there's still abnormal looking skin in that picture. There's scar there. What's great, though, for the patient is that that tissue doesn't hurt anymore. It's not leaking potentially foul-smelling drainage every time they move. It's just discolored. But you do need to educate your patients that the cosmesis, the cosmetic outcome of the HS lesions, will improve over time. It will take longer than the activity of the disease state takes to improve, and that our first goal is returning them to function, to take away those symptoms that were impeding their life activities, like the drainage and the pain and the itch and the odor. So 16 weeks to get to a place where you have 100% improvement in that area, not so bad. Another very important thing is sustained results. I like to share with people that my twin sister is an opera singer. And in opera, when they want to break your heart, they introduce you to a wonderful character that you care about. And then that character gets sick. Think about La Bohème or La Traviata. My sisters played both Mimi and Violetta in those operas. The patient gets sick, the person that you cared about and invested in this opera. And then they rally and they have a beautiful aria. And you're relieved. You're like, oh my goodness, they're going to make it. And then they die. That is how opera breaks your hearts when you're watching opera. Now, as dermatologists, especially those of us who have practiced throughout the biologic era, we have met medications that could break our patients' hearts because they work very well at the beginning and then the patients lose effect. So sustained response is very important. And here you can appreciate the high score 50 response was continuing to increase, with 81% of patients achieving high score 50 by week 48, and with sustainability as well. And I really love to see that crossover where you see the dotted line and the patients who were previously on placebo crossed over to the active treatment arm and were able to start to catch up with those who started on active drug. Now, a lot of people ask, why are the people in the placebo arm improving at all? I think it's human care. I think it's the fact that there's another person who is taking their disease state seriously and that they have the potential to have a medication that's going to work and is going to give them relief. Because there's a lot of connection with the patient's psychosocial wellness on both sides of the equation. Our patients that have HS really suffer, and when the HS is worse, they suffer more, and when they're suffering more, their HS is worse. It's really a terrible vicious cycle, and we can help break it. Here you can appreciate this analysis showing more than 60% of patients sustain their high score 50 at week 48. So again, a medication that is not going to break our patients' hearts. Very important that they're able to sustain their improvement and stay on therapy. Now, some patients, this is the great part of the story, exceeded high score 50, reaching high score 75, 90, and even 100. Almost 30% of patients were able to achieve a high score 100 by week 48. We did not used to think that was possible. With this medication, we really are able to elevate our expectations and give our patients access to an effective therapeutic that will maintain their response. And again, here you can see on the long-term extension, results sustained up to 3 years, with patients maintaining and even improving their high score, getting up to 41% high score 100. That is phenomenal. As a teacher, lifelong, I've been teaching since I was 15 years old. I taught swimming lessons for the Red Cross starting at age 15, and I've been teaching ever since. If I had 41% of my students get 100, I would be a pretty darn happy teacher. This is a phenomenal medication. It works very well, and it has sustained results. Patients that are treated earlier in their HS journey may be more likely to achieve a higher clinical response. So if you really want a stellar class, you've got to start your treatment earlier. HS is a structural disease. There has been for some time the philosophy that people are going to hold on to this medication for their worst patients. But I would argue that a best strategy is as soon as you see your patient going into moderate to severe HS, you get them on an effective therapeutic that interferes with disease progression. We wouldn't wait until somebody who had rheumatoid arthritis couldn't pick up a pencil before we started something to modify their disease course. For the same reason, we shouldn't wait until a patient is scarred to the point of dysfunction before we take the BIMZELX out of the refrigerator and give them a chance to have a life unencumbered by chronic scarring and drainage. You can appreciate here that the patients who have disease duration less than 2.4 years over time significantly improve their high score rates over those patients who have had disease longer, more than 10.9 years. Now, I will tell you, there is not a single patient that has had HS too long to attempt treatment with, because patients will still improve. But the amount of improvement those patients are going to get will not be as significant if much of their tissue is scarred down. So giving patients access to therapeutics as soon as you identify they're moving into that moderate to severe HS category is the right thing to do, because that's going to give them the best chance to live the most full life. Patients experience sustained HS symptom relief for up to 1 year, and of course, the long-term extension studies showed that those continued on to 3 years. There was a 77% mean reduction from baseline in inflammatory lesion count by week 48, and importantly, no new draining tunnels in 90% of patients by week 48. That is stopping disease progression. That is what we want to do. We do not want to wait until the house is burned down before we turn on the fire hose. When we see the flames, let's get the fire out. We also can see lasting results our patients can see and feel. This is a patient's real photograph. You can see that this patient has 5 inflammatory nodules, but no draining tunnels. If you were waiting for her to achieve Hurley stage 2, you would wait till this got worse. But you can see this patient is in significant discomfort and significant functional compromise because of the area involved. And this patient is getting more and more bumps and abscesses every time she flares. You can appreciate here, as it animates in, that the patient will start to see improvement and that you can actually see clearance. Now she's down to an inflammatory nodule count of 1 with no draining tunnels. We've halted disease progression and created improvement for this patient. Again, there's some cosmetic discoloration there, but I guarantee you this patient is very, very happy with this result because she can move without pain and move without drainage through her life. Let's talk about patient-reported outcomes. More than 90% of patients who have HS report that pain interferes with their quality of life. Now, I don't know about you, but I would much rather be on the green side of the scale than the red and orange color of the scale, because our patients are really suffering when they're dealing with HS. They have skin pain, itch, smell, odor, drainage, and oozing. With BIMZELX, more patients experienced lasting pain reduction. You can see on the left-hand side of this slide that 3 times more patients reported no to mild pain at week 48 compared to baseline, that nice happy green side of the scale I'd like to stay on. And you can also see that 2 times fewer patients reported moderate to severe pain at week 48 compared to baseline. Those are happy patients that are able to be more present in their life. We are not losing the contribution that they would bring to society because they are impeded by pain, because they're on something that works. BIMZELX is the first and only approved therapy that measures the quality of life through the HiSQAL, which is an HS-specific tool. It's more specific to HS than other measures like DLQI, and it assesses 3 areas: those HS-specific symptoms of itch, pain, drainage, and odor, the psychosocial impact of the disease state, including depression, embarrassment, anxiety, concentration, and sexual desire, and their activities of daily living, like walking, exercising, and sleeping, sexual activity and bathing, putting on clothing, working and studying, and like my nephew, choosing what to wear. You can see the scores from the 3 subscales are then individually reported or summed to create the HiSQAL total score, and it ranges from 0 to 68, with 68 being on the top side of the score with the very severe category. Now, the people at UCB did not shy away from difficult patients when they enrolled. In fact, you can see that the majority of patients enrolled in the study fell in the very severe to severe category. The patients were able to drop down from that very severe impact on quality of life of their HS down to a mild impact by week 16. And that response was sustained out to week 48. So these patients went from a life in a cage of pain, drainage, itch, odor, and frustration to being able to deal with it, to it being an inconvenience instead of something that was running and ruining their life. That's a huge difference. Each one of those people is able to be a better version of themselves because they're not dealing with those chronic symptoms. Safety is also very important. Medications that work very, very well but are very dangerous are hard to use. And this is an IL-17. We know about IL-17s. What are IL-17s going to have? Yeast. We're going to have to deal with yeast. If I had HS, I would trade HS for a yeast infection every other week if I could have relief from my HS. And fortunately, the frequency of the candidal infections is nowhere near that. The safety profile in HS was similar to that seen in psoriasis, the things you always see in clinical trials like upper respiratory infections and headaches. Any injectable is going to have potential injection site reactions. Then we bring in the tinea and fungal infections, as well as we worry a little bit about herpes simplex, not a huge signal, but it's there, and we discuss it with our patients, acne folliculitis, and fatigue. The majority of the treatment emergent adverse events associated with BIMZELX were mild to moderate, and importantly, did not lead to discontinuation of treatment. Like I said, I would take a yeast infection every other week if it meant my HS would go away. These patients are not having to deal with anywhere near that burden of side effect, and really very few people would discontinue the medication. There are no contraindications to this drug and no boxed warnings. The warnings and precautions include suicidal ideation and behavior, infections, tuberculosis, and liver biochemical abnormalities, as well as inflammatory bowel disease. One of the reasons that this medication was under a bit of a microscope about suicidal ideation and behavior was because a previous therapeutic, brodalumab, which is also an IL-17A and F inhibitor, had a weak but not zero signal with suicidal ideation, and so this medication was already under a microscope from the jump in the trials. Now, I want to draw your attention to the fact that adjudicated suicidal ideation and behavior rates were very, very low and stayed low across those 3 years of the clinical trial. So this is something that I always talk with the patient about. Anytime there's a signal connected to a medication, I talk about this with all of my Accutane patients. The greatest predictor that somebody's going to have a suicidal attempt is that they've had a previous attempt. If you have a patient that has HS, chances are they've been depressed. This is a condition that very understandably can create mood troubles. But if my patients have had suicidal attempts before, I do like to ensure that they're on stable therapy with a psychotherapist or a psychiatrist, and that they're in a good mental place before we start the medication. Not because I believe that this medication poses any significant risk, but because there is something called a nocebo effect. When you tell somebody that something might happen with a medication, sometimes their mind can sort of make that thing happen, especially if it's something that can be a movable goalpost like mood or suicidal ideation. So we talk about it. We talk about the very low rates in the studies. We talk about the fact that it's understandable sometimes that patients with HS struggle with mood and struggle with depression. It's a condition that takes a lot away from the patient. I'm confident that over time we'll see what we've seen with other medications that are connected to suicidal ideation and behavior, which is that medications that adequately and appropriately and effectively treat conditions that impede and impair people's quality of life and patients get better on, over time gives them the actual opposite of that problem, which is a decrease in those feelings and sensations. It's a very well tolerated safety profile. We do talk about elevated serum transaminases. Those were reported in clinical trials, not at terribly high rates, but it's always reasonable to check if patients are having any symptoms. It's an IL-17, and all of us practicing dermatologists know that IL-17s have a little bit of a complicated relationship with inflammatory bowel disease. If a patient has a family history of IBD but no active symptoms themselves, and I feel like BIMZELX is the right medication for them, I will start them on that medication with a good description and counseling about what signs and symptoms to look out for. If they have active uncontrolled inflammatory bowel disease, I might choose a therapeutic agent for their HS that could also treat their comorbid IBD. You do want to make sure your patients have their immunizations, especially any live vaccines, before they start their BIMZELX. We're trying to avoid the use of live vaccines in patients treated with BIMZELX. And our most common adverse reactions are things that you see in every clinical trial with the exception of the fungal infections. The dosing for BIMZELX is very convenient. It's one of the great pieces of this medication, very easy for patients to use. It's provided either as a pre-filled syringe or auto-injector pen, and very easy for our patients to use with moderate to severe HS, moderate to severe psoriasis, and psoriatic arthritis with coexistent psoriasis. Our patients with HS have 13 maintenance doses per year. They get a dose every 2 weeks for the first 16 weeks, and then they convert to every 4 weeks as the recommended dose. Our patients with psoriasis have only 6 maintenance doses per year. They're treated every 4 weeks for the first 16 weeks, and then they convert to every 8 weeks after that period of time. Very straightforward dosing regimen, very easy for patients to follow, very easy for them to adhere to. Now let's talk about access and patient support. This has been a great feature of this medication in my practice. I have a lot of patients that I take care of that have HS, and we've been able to get them access to that medication through the Bridge program. There's also very good levels of access across multiple different insurers, including CVS Caremark and Optum. And I'm trying to get that slide to load, and I apologize, I kind of went past it. There we go. So Optum actually has The BIMZELX available with just a single step edit for patients with HS. For patients with HS and psoriasis, ESI has a single step edit. And for our patients with psoriasis, CVS Caremark exclusive, it is the first line IL-17 for psoriasis and psoriasis with coexistent psoriatic arthritis. And the BIMZELX Navigate Bridge is phenomenal for eligible commercially insured patients. They can get BIMZELX for $15 per dose for up to 2 years while their insurance coverage is pending. So this is a great way to get patients on the medication so they can get relief. And what's wonderful about that is then you can get them to that rapid response with patients reaching high score 50 and reporting pain reduction as early as week 2. You can see those high levels of efficacy beyond high score 50 going up to high score 75, 90, and even the mythical high score 100, which as you saw in the long-term extension trial, 3 years out, 41% of patients were at high score 100. Patients have lasting symptom improvement continued through 3 years. We're not going to break our patients' hearts with this drug. They have pain reduction with a 3-fold increase in the number of patients reporting minimal to no pain by week 48, moving into that nice green category, the green pastures of minimal to no pain. The quality of life improved in our patients from very severe to mild impact of the disease state on their quality of life, and there's a consistent safety profile across multiple indications. Very safe drug, very straightforward to use. It's very efficacious for our patients, and you can give their lives back with this medication. Thank you so much for coming to learn with us tonight. Thank you for caring about patients with HS. Thank you for caring for patients with HS and providing them access to therapeutics that work.
Thank you so much, Dr. Tarbox. That was wonderful, wonderful lecture, and I really appreciate it. And you explained the suicidal ideation behavior and depression so well that I just want to add one more comment that there is no box warning, there is no REMS program, just to separate it from the IL-17 ANF receptor blocker. So that was really, really very well done. And we already have some questions. I was checking the chat box. Tell me a little bit more about the opera and the heartbreaking the operas. And how do you weigh the durability data from the control trial versus the real life? And how do you set that expectation? How do you convey that message to your patients?
I think that's a very important thing to discuss on the front end with our patients. So I like to be transparent with them and discuss the fact that clinical trials tell us what's possible with the medication under ideal circumstances. The patients are being monitored, they're being supported, they always have access to their medication, they get it right on time. The real world experience tells us what's sustainable in actual patients. So in trials, what I usually say is in trials, we know this medication can produce meaningful and durable responses over months. In real life, what matters most is if it works for you and whether it can keep working. So I like to let them know that the trials give us confidence in the mechanism and the expected response window. In the real world, there's variability, there's adherence challenges, there's comorbidities. Durability is not automatic. And I like to emphasize this with my patients. It's something that you and I maintain together. So disease control requires that we stay on therapy, that we manage our triggers, and we adjust when needed. I don't want to overpromise durability. Instead, I emphasize that we are in a partnership and we're going for a trajectory of improvement. Life happens. Patients' therapeutic regimen gets interrupted, sometimes by insurance, sometimes by happenstance. Sometimes patients are traveling and they forget to bring their medication. And then sometimes patients might have some challenges with things that trigger the disease to become more active, whether that's stress, whether that is sometimes exposures to certain things in their environment, and we like to really work together to co-manage this. I also think it's very important to discuss adherence and persistence over time. So our patients might have the misunderstanding that when they get better, they stop taking their medication. And I like to get in front of that. This is where a lot of therapies fail, not by efficacy, but because of execution, because we don't take the time to explain this to our patients. So I reframe success to my patients to let them know that this is not something like strep throat where I can give you a course of antibiotics and it goes away and you don't have strep throat anymore. You have a genetic predisposition to an autoinflammatory syndrome that I cannot at this time point cure. However, we can manage it very, very well. And I want to emphasize with them that when you start feeling better, that means the medication is working exactly how it's designed to work, and it's preventing further flares and exacerbations of your condition. That does not mean you should stop the medication. We also talk about the things that might be patient-relevant outcomes that we want to continue to improve. So not just lesion counts, but also, are you sleeping better? Is your pain improved? Are you able to choose your clothing without having to think about your drainage? And are you functioning at work? I like to emphasize how much better the patients feel, not just how much better they look, but all of the things they've gotten back because they've been able to stay on therapy. So I can preempt the I'm better, I can stop moment. And I'll explicitly say at initiation that this is a control medication, not a rescue medication. And at this time point, we don't have a cure for this condition yet. So I like to build up confidence in the patients. I like to have frequent visits at the beginning to build trust and reinforce the response. And then we can build out our longer time intervals with clear checkpoints, and we define reasons why they would want to come back sooner. They also know their disease state fluctuates. And I let them know also that good weeks and bad weeks don't mean this medicine has stopped working. This is the way the disease behaves. We are putting a blanket over and pushing it down. It will be so much less bad than it was before. But just because you have an exacerbation doesn't mean that the medication isn't working. The medication is still controlling the disease state and keeping the exacerbation to a lower level so that I can keep patients from disengaging and intervene before they make a decision that derails their treatment.
That was excellent. Now, how often, when do you bring them back in the beginning and then later on? What's your intervals?
It depends a little bit on the patient, but that's a very good question. So when I have a patient that has HS, it's pretty severe, but they understand that this is a condition that they can treat, and they have a higher level of medical literacy, I'll bring them back usually first at 3 months to make sure that they're really starting to get that improvement, because that's really when the therapeutic efficacy starts to gel. However, if I have a patient that has a very high psychosocial burden or low medical literacy, I might bring them back every month until I get to that 3-month mark to ensure they're staying on therapy, that they understand how the medication is working, that they're able to get the medication, and that their symptoms are starting to improve. I think it's really important to be available to your patients with HS because many of them have been ignored or put off by the medical system or dismissed as difficult or pain medication seeking patients, when really, like Miss Leah said, we are not difficult patients. We have difficult lives. We don't want pain medication. We want pain relief. And I emphasize with the patients that the thing that's going to give them the best relief of their pain is getting the inflammation under control. And the way that we do that is consistent use of the effective therapeutic agent.
Excellent. You know, it's a totally, the HS population is a different population than psoriasis.
Yes, very much so.
You are so correct. Yeah. And how about the onset of action, the time frame that you expect time of the improvement, and how do you convey that? Right? Most of our patients are very impatient.
Yes, this is true. This is true. So I like to set expectations early and in layers. So I let them know that we're going to look for a few things as they're on this medication. We're going to look for an early signal that it's working. Then we're going to look for some meaningful response. And then we're going to look for durable control. So early on, week 1 to 2, because this is an IL-17 and they do work fast, the first thing patients tend to notice is that they're not having as much pain because the inflammation is coming under control. So I tell them in the first couple of weeks, you should start to notice that the pain and the tenderness are not as bad as they were before. And I let them know that pain improvement means we're getting in control of the inflammation. The inflammation is what's causing the pain. And that's our first sign that this is working. As we go through, I say around a month, you might start to notice that you're not having as much drainage. The lesions are probably still going to be there, but they're not going to be as productive, as active, and as symptomatic as they were before. Then usually around 3 months, you're going to start to see fewer nodules, less drainage, and fewer flares over time. So I let them know that this is when we're really going to sit down together and decide if we feel like this is moving the needle and getting things better for you. And I almost always see that with this therapeutic. There have been other therapeutics I've used in the past where it was a little bit hit or miss. We might have to add or sprinkle in other therapeutics to get there. Beyond that 3-month point, then we talk about the fact that the condition will continue to improve as they stay on treatment, and that most importantly, we want to prevent flares, because flares create new structural disease, and structural disease, especially tunnels, will always have some activity. So I think it's very important to get patients on board with how things are going to get better, because social media, the internet, modern media world tends to show these miraculous improvements in things, many of which are not real, are AI generated, or are not clear on their time points, and our patients' expectations have been artifactually set at sort of a magical level. So we need to bring them back down to reality and let them understand that this is the most powerful therapeutic that we have access to right now for HS. It has the best efficacy and the greatest likelihood of getting control over your disease. But it is not a magic wand. It is a medication. And we need to stay on this medication and give it time to work, because these structures that you have, these tunnels and these nodules, while they might pop up kind of suddenly sometimes, you know that these have been there for a long time. They didn't show up in a day, they won't leave in a day. But if we control the condition over time, we can see significant improvement. And a strong minority of patients, so 41%, were able to get up to 100% reduction of their skin lesions over 3 years. So giving the medication time to work, I think, is vital, and explain to the patients on the front end that they need to communicate with us if they want to discontinue treatment or if they're getting frustrated, so that we can give them guidance about what to expect, is also very important. I think communication is where we sometimes fall down in the treatment of our patients with HS. And that is a point where we can make an intervention, set expectations, and allow our patients to know the roadmap ahead. Because remember, they've been on this very not fun roller coaster of flares and exacerbations. And I think that so long as they know what's coming and what to expect, they can buckle down for the ride with us and get to the destination.
Thank you so much. That was really, really very eye-opening, and I learned a lot. I really appreciate it, and thank you for your really expeditious lecture as well, because we're finishing early, and I'd like to thank, yes, so people always appreciate, right? Finishing early, and give everybody is another extra 10 minutes with family time and dinner time. So I thank you so much. I'd like to thank our supporter, UCB. Inspired by patients, driven by science. I like to thank them. And now that we're done with the UCB program, I can tell you all about our next program, which is going to be on April 23rd on Thursday, 7 to 8 p.m. And Dr. James Sung is going to join us, and he's going to tell us all about a novel oral peptide in moderate to severe plaque psoriasis. Thank you so much, everyone. Have a good night. And thank you again, Michelle.
Thank you so much. I appreciate it so much, Leon.
Bye-bye.
Bye.